Hello and welcome to the SimpleMed Radiology lecture series. My name is Dr. Marcus Judge and I am the Radiology Lead. Today will be a lecture on the interpretation of chest x-rays. This lecture is aimed at preclinical or phase 1 medical students and allied health professionals, and so it is pitched at that level. Our learning objectives for this lecture aim to give you the basic knowledge required to help you identify common pathology on a chest x-ray film, including pneumothoraces, cardiomegaly, and rib fractures. Before interpreting a chest x-ray, you should be able to assess its technical quality, and so we will cover an easy and quick way to do this. Our previous lecture on the basics of chest x-rays gives a good base to understand this lecture, and so we recommend that you check that out before watching. Prior to looking to identify pathologies, it is important to check that the image you are looking at is as accurate as it can be. If an image is not technically adequate, it can lead to incorrect interpretations and can cause pathology to be missed. We can use the RIP mnemonic for a quick and easy way to assess for technical adequacy, looking at the rotation of the patient on the film, whether the patient maintained adequate inspiration while the film was taken, and whether the image is adequately exposed or penetrated. The physical rotation of the patient relative to the X-ray source can strongly affect the image outputted. Sometimes, particularly for patients who are ill or in pain, adequate rotation can be very difficult. Rotation can be assessed on a film by measuring the distance between the medial end of one clavicle, seen here in blue, and the spinous processes of the spine, seen here in yellow, and then comparing that distance with the same on the other side. They should be equal. A small amount of rotation is acceptable, but large amounts can lead to inaccurate cardiac sizing, hyperlucency of the nearest lung, or simply misdiagnosis on the basis of difficult to interpret signs. When taking an X-ray, the patient is asked to take a deep breath in. This inflates the lungs and allows the bases of the lungs to be visualized properly, as well as giving a better idea of lung capacity. Seriously ill patients and those lying in bed can really struggle to inspire adequately, meaning sometimes signs, particularly at the lung bases, can be missed. To assess for adequate inflation, you can count the number of posterior ribs on a PA film. These are highlighted in yellow on the image. You would expect to see 9 to 10 ribs if there is appropriate inspiratory effort. Too little inspiratory effort can lead to incorrect interpretations of lung volumes, over-prominent lung markings making pathology difficult to discern, and a falsely enlarged cardiac silhouette. Penetration and exposure are terms often used interchangeably, although it is technically incorrect to do so. As discussed in our Basics of Chest X-rays lecture, exposure relates to a number of factors and determines how much and for how long X-rays are fired at the detection plate through the patient. This means images can be under or overexposed. The radiographer can adjust these factors to help create a properly exposed image, and they can be helped further by modern rewindowing technology. On the left, we see an example of an overpenetrated image. This causes fine details and the lung fields to be improperly visualized, which leads to a clear possibility of pathology being missed. It can be difficult to identify that a film has been overpenetrated. The image in the center shows an underpenetrated image, i.e., insufficient X-rays have passed through the body. This causes a similar loss of detail, but this time due to the depth of visualization being inadequate. The easiest way to assess for good penetration is to identify whether you can clearly see the vertebral bodies behind the heart, as labelled in blue on the third image. If you can see these well, then the image should be adequate. We have previously outlined a simple, systematic approach to chest X-ray interpretation in our Basics of Chest X-rays lecture using the ABCDEF mnemonic. It is important to have a structured approach in order to not miss pathology or fall prey to finder's bias, whereby you may stop looking for further pathologies after finding a single one. Here is an overview of the systematic approach that can be used for optimal chest X-ray interpretation. As part of A, our airway assessment from our systematic mnemonic, the primary signs to assess for are tracheal deviation and its causes, the steeple sign, and signs of foreign body aspiration. Tracheal deviation, as the name implies, is deviation or movement of the trachea from its usual place travelling down the midline. The trachea is attached to two bronchi, and therefore the lungs, and so if it is deviated to either side, there is usually either something pushing it away from one side or pulling it over to the other side. On the left, we can see a massive right-sided tension pneumothorax with shift of the trachea, outlined by the dashed line, to the left. The heart is actually also displaced to the left. You can identify the pneumothorax by the hyperlucency of the right hemithorax and the absence of any lung markings on this side. It looks very dark and empty. The right-hand image also shows a tracheal deviation. However, this patient was in his 70s and had a background of lung cancer. In this case, the tracheal displacement is due to a massive right pleural effusion, opacifying almost the entire right hemithorax. This was a malignant pleural effusion caused by pleural metastases. If you look carefully, you will see multiple nodules throughout the left lung, which were also metastases, plus a small left pleural effusion. In this case, the fluid in the pleural effusion is pushing the trachea to the left. It can be helpful to know some of the causes of tracheal deviation to and from pathology. This can help guide your assessment and apply context to the pathology you are seeing. Pathology causing displacement away from itself usually causes an increase in pressure or physically pushes the trachea away. A deviated trachea can be a vitally important sign of a tension pneumothorax, though those with clinical suspicion of tension pneumothorax should generally be treated empirically, and radiological assessment should not delay management. Pathology causing displacement towards itself usually causes an increase in weight of one of the lungs relative to the other, or causes a collapse of the lung on that side. This literally causes the trachea to be pulled across. There are a few signs that can be helpful in identifying certain pathologies. An interesting sign is known as the steeple sign, and refers to the tapering of the upper trachea on a frontal chest radiograph, reminiscent of a church steeple, suggestive of croup, a primarily pediatric viral breathing condition presenting with a recognizable barking cough. Airway foreign bodies are ingested objects that have accidentally made their way into the upper airways and lungs. They occur particularly in children and are potentially fatal, which is why immediate recognition is important. Unfortunately, delayed diagnosis is common. Around 70% of foreign bodies are organic, most commonly seeds and nuts. Inorganic foreign bodies vary dramatically and can include teeth, coins, pins, pens, and crayons. Aspirated foreign bodies have a predilection for the right tracheobronchial tree, given the wider and steeper structure of the right main bronchus. The radiographs show a peanut inhalation, causing a lung collapse in the right middle lobe. Spotting these signs can be very technically challenging. The peanut is highlighted in blue. Bone pathology is commonly missed on chest x-rays. While a chest x-ray is not indicated for the diagnosis of rib fractures, it can be very important to pick up on serious fractures, particularly flail fractures, which can cause serious respiratory compromise. Importantly though, a chest x-ray may miss up to 50% of rib fractures, and so it is not reliable as a rib fracture assessment modality outside of the acute environment. Rib fractures are a common consequence of trauma and can cause life-threatening complications. They are often associated with other related injuries, and a rule of thumb is that the greater the number of rib fractures seen, the more likely a related injury is to have occurred. Examples of related injuries include pneumothoraxes, brachial plexus injuries, and atelectasis. Rib fractures can be difficult to see, so often assessing for their complications can help to identify them. The example shown identifies 3 displaced posterolateral rib fractures on the left-hand side of the chest. You can see how this can be difficult to pick up on. When a rib is fractured twice in different places, the term floating rib is used to describe the fractured segment. When 3 or more contiguous floating ribs are present, this is called a flail chest, a life-threatening complication of rib fractures. A flail chest is usually associated with significant blunt chest wall trauma. With a flail chest, the continuity of the chest wall is disrupted, and the physiological action of the ribs is altered. The motion of the flail segment is paradoxical to the rest of the chest because the flail segment moves inward while the rest of the chest wall moves outward. The diagram shown is an excellent graphical depiction of a flail chest. Lung hyperinflation is a common feature of patients with chronic obstructive pulmonary disease, known as COPD, and can lead to the notable radiographical presentation of barrel chest, as seen on the chest x-ray shown. COPD causes lung hyperinflation via destruction of the lung parenchyma and airway defect or remodeling, with almost all cases being secondary to smoking. Hyperinflation presents with a flattened hemidiaphragm, more than 10 posterior ribs being seen above the diaphragmatic level, and an increased anteroposterior diameter of the chest, with the latter being named barrel chest due to a chest in this case looking like a storage barrel, for example for whiskey. As part of C, we assess the cardiac silhouette. Primarily, the size of the heart is of most importance. However, incidental findings and assessment of the hilar lymph nodes can alter management dramatically. The cardiothoracic ratio can be used to identify an enlargement of the heart borders, which is most commonly from cardiomegaly, but can be due to other processes such as pericardial effusion. The cardiothoracic ratio must be measured on a PA chest x-ray, and it is the ratio of maximal horizontal cardiac diameter to maximal horizontal thoracic diameter. This can be seen in blue and red on the chest x-ray. A normal measurement is about 0.42 to 0.5. An enlarged heart can be a sign of heart failure, and so you may expect to see elements of pulmonary edema or congestion alongside an enlarged heart. Dextrocardia is a congenital cardiac malposition in which the heart is situated on the right-hand side of the body rather than the left, with the cardiac apex pointing to the right. While it would be ideal for this to be picked up on clinical examination, it is important to not be confused when seeing this 1 in 12,000 presentation. When approaching the chest radiograph of someone who appears to have dextrocardia, it is important to exclude spurious dextrocardia first. This is by far the most common cause of a dextrocardia-like appearance and is a technical error due to the radiographer or technician inadvertently flipping the image over in the mediolateral plane when processing the image. Enlargement of the lymph nodes in the chest can be a sign of multiple pathological conditions. Of particular importance are the hilar lymph nodes, which can be seen clearly when enlarged on a chest X-ray. Hilar lymph node enlargement can arise from many causes, which include infections such as pneumonia and tuberculosis, malignancy with lymph node spread, sarcoidosis, and also inorganic dust diseases such as silicosis. The chest X-ray shown shows large bilateral hilar lymph node involvement in a patient with sarcoidosis. Today, we have covered the importance of assessing technical adequacy on chest X-ray films and how to do this. We have also identified a number of key pathologies from the A to C part of our systematic interpretation mnemonic, with the remaining D to F part due to be covered in our next lecture. There is no substitute for experience when it comes to interpreting scans, but an idea of what you might expect to see can help to guide learning. That is the end of this lecture. Be sure to check out simplemed.co.uk for hundreds of free articles, thousands of free questions, and any support with questions you might need. Thank you for listening, and goodbye.